So we're going to talk about abdominal aortic aneurysms briefly, and it's one thing that, yet another thing I'm pretty passionate about as a vascular surgeon. We see it all the time, and I always, when I'm talking about abdominal aortic aneurysms, forgive me if you've seen this before, but I love this presentation because it goes all the way back into December 1948. A 69-year-old gentleman talked about significant pain in his upper abdomen to his physician, and he'd had this pain for a long time. He was a pipe smoker, slightly overweight, and they noticed a pulsating mass in his abdomen in physical exam. And so it's present, think about that case, and we'll come back to that in a few minutes. Abdominal aortic aneurysms are present in upwards of 8% of males greater than the age of 65, and it's the 14th leading cause of death in the United States. And a ruptured abdominal aortic aneurysm causes upwards of 5% of sudden death in the United States. Of 100% of all the patients with ruptured abdominal aortic aneurysms, 75% of them will die before ever even getting to the hospital. Of those that get to the hospital, 50% die before they even get to the operating room. And of those that get to the operating room, most of them, or over half of them, don't make it through the operation. And so when we're talking about abdominal aortic aneurysms, we're talking about below the diaphragm. And classically, an abdominal aortic aneurysm comes off below the renal arteries, although we do see quite a few of them that involve the renal arteries and the mesenteric arteries or whatnot. How do you find the aneurysms? Well, clinical suspicion, patient history, high index of suspicion, obviously increasing age, male gender, history of blood pressure, history of peripheral arterial disease are definitely positive variables for abdominal aortic aneurysm. Also, family history of abdominal aortic aneurysm. There's just definitely a genetic component to it. History of tobacco abuse, and we'll get into patients who we screen for in just a second. But as patients age, history of smoking, definitely increased risk of aneurysm formation, and to the point where the Medicare allows for a one-time screening in those greater than 65 with significant history of smoking to evaluate for abdominal aortic aneurysm. And this is reinforced by the U.S. Preventative Services Task Force in men ages greater than 65 who've ever even had a cigarette. And Medicare and SVS back this up such that they will pay for that one-time screening. So the number one test that we use that's a non-invasive test for evaluation of abdominal aortic aneurysm is ultrasound. Sensitivity is very high to evaluate and rule out aortic aneurysm. If we do see an aneurysm, then oftentimes we will do a different test, a CT abdomen or an MRI. But as a screening test alone, abdominal aortic ultrasound is really a great test. And even in the obese patient, you can usually get a pretty decent view. How do the patients present? Well, sometimes they'll have abdominal pain, flank pain, pulsatile abdominal mass. It's amazing. You'll see almost an alien coming out of their stomach, and you ask them how long it's been there. It's been there for a long time, and did you just ignore it? Pretty spectacular. So who do we fix? Patients typically greater than 5 centimeters in diameter. There have been several trials over the years that have looked at fixing patients who are asymptomatic of less than 5 centimeters, and the risk-benefit reduction seems to be at about a 5 centimeter cutoff. Also, patients with saccular aneurysms, we think those are a little bit higher risk. This is a saccular aneurysm right here. It's just a focal outpouching. Oftentimes they outpouch anteriorly, and those that are rapidly enlarging, greater than 5 millimeters growth in 6 months or greater than 1 centimeter in a year, we will go after. We think those are a high-risk type aneurysm at a higher risk of rupturing. Typical medical management for all peripheral arterial disease: stop smoking, antiplatelet agents, statin therapy. Statin therapies definitely, especially with abdominal aortic aneurysms, are incredibly important. Dr. LeSar earlier mentioned the anti-inflammatory effect. As with all forms of peripheral arterial disease, it's an inflammatory type disease. And so putting them on statin therapy has been shown to potentially improve mortality, especially after repair. So that case that I was discussing earlier, Dr. Rudolf Nissen took the patient to Brooklyn Jewish Hospital, and found a grapefruit-sized aortic aneurysm. Back then, they opened up the patient's belly and wrapped the aneurysm in cellophane, which created intense fibrosis to strengthen the abdominal aortic wall. And Albert Einstein himself survived 5 more years after this operation. Unfortunately, one day he developed severe abdominal pain and succumbed to the aneurysm rupture. Open surgical repair, the definitive type of repair that we do now, we don't wrap them in cellophane anymore. We've moved on from that. We actually, replacing them with a homograph was first described in 1952, and then they used a woven polyester fabric in the later 1950s. Contemporary series have perioperative mortality anywhere between 1% and 5% for open repair of surgical aneurysms with the improvement in surgical anesthesia and modern medical techniques. But typically we expose the aorta and essentially replace it with this graft. We use Dacron or Gore in replacing it, and sometimes we'll even use cadaver. This is a cadaver aorta, and this is the Dacron woven fabric that we can use. But now it's the future. We've advanced modern techniques. Most of our aneurysms now are replaced with endovascular grafts, and we implant them in modern labs like this that have fluoroscopy. The grafts are also oftentimes made of Gore or Dacron, but slide up on a wire and a catheter and are implanted in endovascular fashion. And we can do these in about a half hour, 45 minutes, and the patient goes home the next day. We can often do it with percutaneous access through a very small incision, place the graft in, and we place a main body graft up to the level of the renal arteries and then cannulate the contralateral gate and slide another stent on, and all the blood flow goes through the graft and takes all the pressure off the wall of the aneurysm. There are several different companies that provide grafts, and we can do it on even crazy anatomy. This is the renal artery coming off here, and we land the graft right at the renal artery and exclude all blood flow into that aneurysm sac. Pretty neat, and we can even do this in fairly tortuous anatomy. So we use a CT scan to size the graft, size the aneurysms beforehand to guide our therapy. We can do this with non-contrasted CTs, but we like to do it with contrasted CTs preferably. Oftentimes the grafts have suprarenal fixation to allow for proximal fixation so they don't slip over time. And with complex anatomy involving the mesenteric or renal arteries, we can even drill holes through the graft, and some grafts are pre-made in this way such that we can slide stents and perfuse the kidney arteries as well as excluding flow from the aneurysm. This is called a fenestrated endograft. This is a 3 or 4 vessel fenestration. This looks like a 3 vessel fenestration that we did with blood flow into the superior mesenteric and bilateral renal arteries. This was a patient that was followed by vascular surgery for several years with significant growth. Initially found on ultrasound and followed with ultrasound. The aneurysm at 1 year was 4 centimeters and then quickly grew to 4.6 centimeters in less than 6 months. Had aneurysmal bilateral common iliac arteries as well. Took them to the operating room after CT scan imaging and deployed the endograft with suprarenal fixation. And the patient goes home the next day. Does anybody know who the actor is in the bottom left of your screen? He won an Oscar and actually refused an Oscar. His name is George C. Scott. He actually died of a ruptured aneurysm, so it's fairly prevalent. He was a long-time smoker and whatnot. Why do we do this? Because the risk of rupture greater than 5 centimeters is fairly significant over the course of the years. These are the stats in almost 10% risk of rupture of greater than 5 centimeters per year. Once it gets over 6, there's upwards of 20% risk of rupture per year, and upwards of a 33% risk of rupture of an aneurysm greater than 7 centimeters per year. A rupture is due to the loss of integrity in the wall. If a physician suggests a rupture, that's a surgical emergency. That means we drop everything they do. And so if they present to an emergency room, CT scan is usually performed, and they're transferred to a tertiary center as fast as possible. We'll get them to the operating room, lights and sirens. We'll put up an occlusion balloon if we're doing an endovascular, which we almost always do now, and that stops blood flow, gives anesthesia time to catch up. We practice permissive hypotension, which decreases the amount of blood loss. This is obviously from an open repair, but sometimes we will use those endovascular balloons to stop blood flow while we're getting things in order to get the patient going. Again, there's extremely high mortality if a patient presents with a pH less than 7.2, pretty significantly low blood pressure, age of greater than 76, their risk of mortality is extremely high. If we do this open, an emergent setting, the risk of renal failure, respiratory failure, myocardial infarction, abdominal compartment syndrome are all extremely high too, complicating things. If we can do it in an endovascular fashion, the patients do much, much better and potentially can leave home even the next day. Upwards of 90% of ruptured aneurysms nowadays in the 21st century can be treated with in an endovascular fashion. This is a rupture we did last year and did it pretty quickly, and the patient went home. That's what you aim for. So thanks for your attention.
Our next two docs, we're going to be talking about neurogenic causes of claudication. We talk a lot about the vascular causes today, but there's another whole side of this, and if we can hopefully pick out some differences, maybe we can figure out what to do. And Dr. Chris Lewis is kicking this off.
Hold on, I got to see how to fix this. Just the arrow moves it?
Big green arrow.
Okay, cool. Hey, my name's Christopher Lewis. I've been a chiropractor for 20-something years. Been in Chattanooga for probably about 17 years. Neurogenic claudication, everybody sees, all right? So I just want to come up here and explain, different approaches, and so you guys understand what we do, because a lot of people don't understand what we do. So let's get started. All right, so I'm going to briefly, this presentation, we're going to briefly define neurogenic claudication, and then also how it impacts the mobility and the quality of a person's life, and then review the chiropractic approaches to it, so you guys understand what we do, and also interprofessional collaboration. Basically, the pathophysiology is nerve compression for spinal stenosis or lumbar degeneration. Everybody goes through it as you get older. Discs degenerate, discs can swell, ligamentum flavums can thicken. These are different things that can give you a problem with it. Symptoms, pain, numbness, and weakness in the lower back, especially the gluteal area in the legs, typically worsen when they walk. There's a thing that we call shopping cart syndrome, is the patient's always leaning forward. So the relief that they get with neurogenic claudication is leaning forward, sitting, leaning forward. Sciatica is a little different. You sit down, it makes it 10 times worse. So why do they lean forward? Well, if you look at the diagram, when you lean backwards, the canal gets smaller. When they lean forward, the canal gets bigger, and it relieves their problem. So forward bending is what they want to do. But constant flexion leads to muscle imbalances in the lumbar spine and the pelvis. This is known as lower cross syndrome. Lower cross syndrome has to do with basically your balance muscles against your phasic muscles. So balance muscles, your brain basically takes care of that. That's why you don't fall over. You're doing stuff. Phasic muscles, you could move. The difference is the movement muscles, they don't have enough energy to last a long time. But your balance muscles, you can sit a long time, you can stand, keep your posture. When it becomes imbalanced, and you're leaning forward, your phasic muscles take over, and that causes a whole host of other problems. In lower cross syndrome, patients also complain of low back pain, hip pain. The postural deficits associated with lower cross syndrome are known contributors of many lower cross or lower extremity diagnoses. Greater trochanteric pain, iliotibial band pain, what I call fake sciatica, which I'll explain that in a minute. Iliotibial band syndrome, knee pains, plantar fasciitis. Poor posture can negatively affect proprioception, balance, gait, and functional performance. And the older you get, it increases your mortality rate. Better chances of falling. So muscle imbalances can lead to what's called trigger points. A lot of people don't know what trigger points are, but basically they're muscle knots that refer pain to other places. One of the number one things that's affected is the gluteus medius, and the gluteus medius, when contracted, helps straighten your leg. If your gluteus medius is not working correctly, what happens is your foot will pronate and your knee will go in. The problem with that is when you're walking, so that better chances of falling. In the blue area is where you're going to feel the pain. The X is where the muscle knots up. How many patients have you had, they're like, and you think it's bursitis. It's not always bursitis. All right, it's trigger points usually. Now the gluteus minimus, this is the fake sciatica. Gluteus minimus can refer pain down the side of the leg or the back of the leg. The gluteus medius or minimus muscle, if you press on where those X's are, it'll reproduce the pain going right down your leg. This is the patient that comes in, you're trying to figure out if it's sciatica or whatever, but you do the neurological exam, negative. You don't find anything wrong with them. But you can even do what's called a straight leg raiser. You pull it up and pull on the nerve to see if it's irritating the nerve, and yeah, they'll grab their hip. So you might think it's sciatica, but it's not. So this is what can happen. Sorry for the diagram, I think it's kind of funny. Posture problems, muscle strain, balance problems, and pain. Now let's talk about the chiropractic approach to this. Everybody knows chiropractors do adjustments, but they're used to ease mechanical pain, reduce spinal compression, and improve joint function. Now in my office, we also incorporate lumbar decompression. Lumbar decompression reduces disc pressure, nerve irritation, often improving mobility and reducing pain. So when you do lumbar decompression, notice in the diagram it opens up that hole. That's what we're looking for. That helps take the pressure off of stuff. Disc pressure alleviates nerve irritation, and using chiropractic along with that improves outcomes. Now it's not just about opening that hole. The muscles that tighten up when you have this are the muscles that bend you forward. And it's very hard for an old person for you to lay them down and try to stretch them. When they lay back on a decompression, it stretches those posture muscles that are just spasmed, so that helps. Trigger point therapy. We focused on trigger points in the lower back and the gluteal areas because those are the most common. We reduce muscle tightness and pain and improves blood flow. Improves a restful sleep, helps with their gait. Now the way we do it in my office, we do like 3 different things, but you can do trigger point injections if you know where the injections are at. You can do dry needling. You can actually do myofascial release or deep massage, but that hurts. If you do it correctly, it doesn't feel too good. The injections are a lot easier. You can just use lidocaine. You don't need to use a steroid. Lower cross syndrome, it's marked by muscle imbalances around the pelvis. Best thing you can do for that is core strengthening. Your core is stomach muscles and back muscles. Those are your balance muscles. So, and then also hip flexor stretching. Hip flexors are the ones that raise your legs, going up the stairs. Exercises, core strengthening, hip flexor stretching, you have to do both. You can't do one. You can stretch the hip flexors and make them feel way better. But unless you make the glute stronger or the core stronger, it'll just keep reproducing itself over and over. Patient education empowerment is vital for long-term management. By teaching patients about their conditions, exercise, self-care strategies, we empower them to take control of their health. Some things that you can do with the people that are bent forward and their hips are hurting really bad, stuff like that. Tell them to put a pillow between their legs when they sleep, a thick pillow, not a thin one, but a thicker one. What that helps for is the muscle, when you lay on your side, you pull it over that joint, it causes the pain right there in your hip. So less chance of that. And also, I tell my patients to, like when they get out of their car, swing both legs, stand up. And when they get in the car, sit down, swing both legs in. These are just little things that you can help. Self-care, focus on maintaining posture, ergonomics, anything you can do to reduce stress on the spine. Also, interprofessional collaboration, important to communicate among chiropractors, medical teams, and physical therapists, so everybody knows what's going on for comprehensive care and cohesive treatment. We do rehab in my office too, but if the rehab is too much, that's what we call the PT. PTs have better equipment for certain things like balance and less chance of the patient getting hurt. But in conclusion, summary, chiropractic offers multifaceted approach to neurogenic claudication through adjustments, decompression, trigger point therapy, exercise, education, collaborative care. This centered approach combined with communication ensures comprehensive care and better outcome. Thank you.
That was a great primer. This is a well-planned conference. So my name's David Wallace. I'm a spine surgeon and neurosurgeon here in town at Erlanger. Let's talk about neurogenic claudication. I have no financial disclosures, but I did eat about $40.30 in Mexican food from drunk companies last year. So as you know, 84% of adults will show up to their primary care office at some point with back pain in their life. So big burden for back pain as well as leg pain. So of course, claudication, you're going to leave this conference saying claudication, it's always vascular, except when it's neurogenic. So what are the differences between vascular claudication and neurogenic claudication? So my children can help demonstrate. So vascular claudication, of course, gets worse with exertion, worse like walking uphill with my 1-year-old daughter on a hike. So that's our face of vascular claudication versus our shopping cart sign from my 2-year-old pushing around her cart at the grocery store. That positive shopping cart sign of leading forward, giving relief, is our neurogenic claudication classically. To drive the point home further, and Dr. Lewis might steal my next slide, but Dr. Harris should put his ads all over Walnut Street Bridge and say, if you can't make it up Walnut Street Bridge without leg pain, we can help, because you got to be thinking vascular, okay? Versus I would advertise at the bottom of the shopping cart and say, if you can't make it without Walmart without leaning forward and reading my sign at the bottom, then you got to come to your neurosurgeon or chiropractor for further evaluation. So the conservative treatment focuses on 4 things. We certainly don't have enough time to go through all of these, but just briefly, I'm sure you guys can tell me better, but first-line therapy should include NSAIDs as well as topical treatments. Steroids are helpful for an acute exacerbation, but of course not a good chronic option. Muscle relaxants can help with the muscular pain, especially sleeping at night. Neuropathic pains have certain roles, especially with crossover with neuropathy and diabetes. And narcotics, of course, are only for limited use after surgery. The physical interventions are mostly that core strengthening and back flexibility exercises, and that can be done through a number of ways. Physical therapy, of course, is very common. We, of course, have a home exercise program as well that we prescribe a lot and through our office if folks don't have the means or transport able to get to and from PT sessions. Even doing yoga or chair yoga YouTube videos are a great start. And then we talked about massage, decompression therapies like an inversion table, and chiropractic manipulation as well. Do injections have a role? It turns out this is one of the few things in medicine we have a good randomized placebo-controlled trial. So they took a couple hundred patients in each arm and did steroid injections for spinal stenosis and did lidocaine placebo injections. And it turns out after 6 weeks there was essentially no difference. So for spinal stenosis, which is going to be your number one cause of neurogenic claudication, epidurals really don't have much role. If you need to, make it through to get somebody to a wedding or something like that, sure, maybe you can buy a couple extra weeks. If it's somebody who's highly motivated and wants to do more PT and just needs an extra couple of weeks to buy time, perhaps that it can give them a couple extra weeks of loosening up so that they can participate in PT, but it's unlikely to make the long-term difference. So injections really don't have a great role in neurogenic claudication. And then we have the kitchen sink as the fourth pillar. Don't really have time to talk about the mental interventions, but kitchen sink, you can consider TENS unit for stimulation as well as acupuncture. And acupuncture is covered by most insurers now as well for chronic low back pain. Imaging modalities, if you can get a patient to my office having had some physical therapy, having tried some NSAIDs, and having an MRI scan, I will be over the moon. I'll be very, very happy. X-rays are sometimes required, and they are helpful mostly for deciding about dynamic instability as playing a role in stenosis. If there is instability, then we often have to think more about fusions, but of course we want to start with the least invasive option, which in my hands is a decompression. So MRI scans are most important. X-rays with flexion extension films can be very helpful, and really CT scans, DEXA scans, and nuclear medicine bone scans are really only important if we're considering fusion, bigger surgeries, more chronic back pain than we are thinking about leg pain. And of course, fusions aren't a great option for run-of-the-mill back pain. So then we get to surgery, the stuff I enjoy doing. In my hands, the most effective treatment is going to be a minimally invasive laminectomy, and we'll talk more about what that involves. Fusions are really only indicated if there's dynamic instability, and there's lots of debate and lots of literature. I think if you're sending certain groups of patients over to certain surgeons and they always come back with a TLIF or a fusion, that surgeon may have an ex-wife to pay or boat payments to make, but I don't think it's the standard of care for back pain. And then there's other more experimental trials like these minimally invasive decompression devices that typically aren't done by surgeons, often done by pain management doctors. And among my group, we're pretty wary of those kinds of devices. Great. So what does a minimally invasive laminectomy look like? So we use these tubular dilation systems. So we start with a dilator that's about 3 millimeters and then work our way up to 18 millimeters. And by doing this, we're able to split the muscle and split through the fascia rather than cauterize and remove a whole bunch of bone. Or a whole bunch of muscle tissue. So that's really important because we talked about one of the contributors to stenosis and degeneration is weakening of those muscles. So with minimally invasive techniques, since we're not cauterizing muscles, since we're doing much less tissue damage, that posterior chain can stay much stronger. So hopefully lessen the likelihood of a second surgery, lessen the likelihood they'll go on to need a fusion. So once we have done the dilation, we have, as you see, anywhere from 3 centimeter long to 9 centimeter long tubes. That'll be our working corridor. And then using small instruments under a microscope, I can then go in and do the work I need to do to remove overgrown disc fragments, overgrown ligaments, and hypertrophied bone to reopen the spinal canal without necessitating a fusion. These are typically outpatient procedures. They are under general anesthesia. So here's some index cases. These are cases I've done in the last 3 months, just to make sure I had good enough outcomes, long-term outcome that they were worth talking about. So this is a classic combined patient. You'll see on his x-ray, he's a VA patient, so he already has bilateral iliac stents for his peripheral artery disease. I thought it'd be appropriate. So this is what a healthy level looks like. So you can see our cross-section here. This is what his good levels look like. He has reasonable disc height. You can see let's try. You can see his central canal there, plenty of room for his spinal nerves and spinal fluid around, versus his symptomatic level, where you see a little bit of spondylolisthesis or slippage between that L4 bone to that L5 bone, that little overlap, and then you can see how the spinal canal narrows to next to nothing from overgrown ligament mostly. Right, this is a patient we take for, again, this is a patient who's chronically on oxycodone, who's a smoker, who has peripheral vascular disease and plenty of risk factors. But we do a surgery that takes an hour. He loses less than a coffee creamer's worth of blood and goes home the same day. And 3 months out, he's doing very, very well. Right, so this is the intraoperative x-ray. There you can just see the part of his stents there at the bottom for his peripheral artery disease. And you can see those curved instruments through that tube that we talked about, docked over the lamina, and how we make our approach. But Dr. Wallace, you picked a patient with a BMI of 18 for your first patient. Well, I decided to also show you one we did with a BMI of 50. So this used to take a incision from here to here in order to get down, and you again have to split through all these paraspinal muscles, which are so important for maintaining strength and balance. So again, here's a healthy level where we see even with epidural lipomatosis, even with the fat tissue in the spinal canal, this is her subcu tissue, of course. And then you see at her L4-5 or symptomatic level, you can see how our spinal canal is next to nothing. So, you can tell this patient to lose weight and her back pain will get better, but she can't walk because of the stenosis and the severe pain she has in her legs. So again, we took her for using the same technologies, but just using the 9-centimeter tube instead of the 4-centimeter tube. We're able to make that same approach to the spine, get her an outpatient surgery, and get her home the same day to free up those nerves and get her walking better. That's the AP view of the x-ray, just to give you more idea of what the tube looks like docked down there. Right. If you ever want to talk to me about spine surgery or cheeseburgers, you can follow me on Instagram. Right, I think we have a panel session coming up soon if you have other questions. Thank you so much.
So I love the multidisciplinary approach to care for patients because we all tend to get in our own little box, our own little world sometimes, and we don't see this. And sitting back with Dr. Lewis, and he's going, "Oh, that's awesome, and that's so cool," and watching some of the surgery that you're doing, and it is cool, and it's awesome that we have that we can sit and talk about some of the problems because we know that to live long, you have to have a strong heart, you have to have strong lungs, and you have to have strong thighs. Those are the 3 conditions to living long. You have to have good muscle, good balance, good strength, and you can't fall when you're 80 years old because you tend to break things. So let's talk a little bit about, in this section we were talking about aortic aneurysm disease. This is going to be popliteal aneurysm disease. The popliteal artery is the artery directly behind the knee joint, and it's at a high flexion point. There are other arteries that kind of stabilize that, but sometimes you can get a development of a dilation in that artery that we call a popliteal artery aneurysm. Now, this is the most common peripheral artery aneurysm. It's about 70 to 80% of all the peripheral aneurysms, and higher incidence in male, significantly higher, 20 to 1 to female. 50% of cases are bilateral, and aneurysms tend to expand over by 10% per year. Now, the pathogenesis is atherosclerosis. This is all what we've been talking about today. And the problem is dilation and elongation. It's not typically rupture. These aneurysms don't rupture and patients bleed. What they tend to do is they tend to clot. And when they clot, then we're in big trouble. It's been categorized as the sinister harbinger of sudden catastrophe. It sounds like my young child who talks to me about things like this. But popliteal aneurysms are unpredictable. They have severe complications, chronic embolization to the foot and lower leg, thrombosis, and acute ischemia. And the cumulative risk of complications is, in 70% of cases, is at 5 years. So when these aneurysms do act up and they clot, it's only about 50% of those patients that we can actually save their leg at that point. So this is the symptoms. They have local pain in that area. They may describe local swelling in that leg, that calf, because of the compression of the venous system, or you might feel a severe pulsation behind the knee. And if you find that, that's something that we need to see and work up. Now, additionally, acutely, patients can have embolization syndrome where they have different colors to their toes. We call it blue toe syndrome. That's an embolization syndrome. Or they can have claudication symptoms, rest pain, and even gangrene form in the lower leg because of the embolization process. 20% of patients will present as critical ischemia, high risk for amputation at that point. We are in a dog race at that point to try to get the circulation back to the foot, and half the time we're unsuccessful. So if you find an aortic aneurysm in a patient, you feel their belly, and this one you can see from a mile away, literally, the patient said that my heart fell down to my belly, and that's how he described it. And you could actually see that aneurysm. But if you find an aortic aneurysm like that, about 10 to 12% of patients will have a popliteal aneurysm. So there's a correlation there. If you find the popliteal artery aneurysm, it's the reverse. You have 40% chance of having an aortic aneurysm. So it's also very important to, if you find one, you're looking for the other. Indication for repair for symptomatic aneurysms is regardless of size. If they're having embolization or pain, we fix them. If they're asymptomatic and they're about 2 centimeters, we will fix those aneurysms. If they're asymptomatic in 1.5 centimeters with some clotting that's starting to form, because that's where the embolization process happens, that's when I have a conversation with the patient and say, time to fix it. So how do we fix it? So here is a patient with a popliteal artery aneurysm. You can see it's very dilated. The outflow looks to be okay. There's one vessel that looks to be gone. And we can use a stent that actually has a covering to it. We call it a covered stent. And we can actually pass that across the lesion and deploy above and below the aneurysm, which will block that aneurysm, preserving flow down to the lower leg. The patient, this is a 6-French, this particular patient, we use a 6-French at the ankle. We came up, we were fixing some PAD problems, and we thought we were doing such a great job, and then next thing you know, I find a popliteal artery aneurysm that we discovered. We can move to a little bit higher sheath and then actually repair that again with a covered stent to actually fix that aneurysm. So it's in patients with PAD, it's just part of the deal. If we find them, we do want to fix them. Sometimes it's surgical therapy. We place the patient on their belly and we open behind the knee. We actually have to open the aneurysm and sew a piece of their vein into that position to reconstruct that artery. Sometimes we have to create the bypass to the artery. We ligate the artery distally. That bypass then comes down to the below knee popliteal on that right panel. And you kind of see that red diagram with the big X. That's where we ligate the artery from below. So you can ligate above, ligate below, and do a bypass around. That's probably about 20% of patients. Most of the patients we can treat with an endovascular technique. This patient, 71-year-old, presenting with a history of AAA, has claudication, has numbness, no rest pain, former smoker, and then non-palpable dorsal pedal pulse. So we prepare the patient. This is the area of disease that we're fixing in the right panel. And we do the angiogram, and we do the angiogram, and we do the angiogram. We can't seem to find the aneurysm. It's because you have to look at it from an ultrasound. The only thing that you saw on that angiogram was where the blood flow is going. You don't see the clotting that is inside the aneurysm. And so as we use intravascular ultrasound, we can look at the artery that's proximal and fairly healthy, and distal, very healthy. But we also see that the popliteal aneurysm is large with a tremendous amount of thrombus that's sitting inside that vessel that could easily fracture and travel to that lower leg. So we place a small stent to repair that. We continue to look lower, and we found a second aneurysm at that knee level, which is not uncommon, and that also had a stent repair, because we had a second stent there. And now we have flow into the lower leg, and everything looks pretty good. You can see the intertibial artery has occlusion, more than likely an embolic event at some point, but that's the pathophysiology of these aneurysms. They embolize. Next patient, 72-year-old, claudication, rest pain. He failed cardiac rehab, and that's kind of how we got him. He had a +3 popliteal pulse and a non-palpable pedal pulses. He has fairly severe tibial disease, and we took him to the operating angiogram suite. We can see the artery has ectasia, some dilation of that artery, and then you can clearly see where the aneurysm is. You can see that the AT and PT are gone, pretty much gone. The perineal artery is the main outflow to his foot. He was having symptoms of pain in the foot, so we have to deal with not only the aneurysm but also the occlusion that is that's there. So there's the popliteal aneurysm, and that's after we repair that with a stent. This is actually where we repaired the posterior tibial artery with atherectomy and angioplasty to get the circulation back into the foot at that level. Lastly, this is a 77-year-old patient with claudication, 200 feet. He can walk 2 miles a day. 2 miles a day. I was impressed. Significant smoker, 2 packs per day for 30 years. He has absent right pedal pulses. He has aneurysms fairly large on the right and occluded, and 2 centimeters on the left, really about 1.5 on the left. And this is the right side. His angiogram showed that the artery came down to the knee level and then abruptly occludes. He has significant collateral networks that he has developed with his walking 2 miles a day. He walks 2 miles a day. And so there really was nothing to do with that. What to do takes longer to learn than how to do it. And this patient, his best option was just to watch him on that right leg. On the left leg, he has a popliteal aneurysm measured about 1.5 by ultrasound. He had adequate distal outflow. The best thing to do was just to leave him alone. He walks 2.5 miles a day. So we really didn't have to do anything with that particular aneurysm. And sometimes when you have enthusiasm about surgery, you can bring a patient backwards, and sometimes you have to have that balance of what to do. And that's the picture, that's my piece, that's my picture from my backyard.